Good evening, everyone. Thanks for joining. I'll wait a minute or two as I can see people are still logging in. We have more than 200 registered for tonight, so I'll wait a minute or two. I think I'll go ahead and start. It's a pleasure tonight to have Professor Dr. Curtin joining us, joining the American Intervention Headache Society series of webinars that we're offering free for our members and even non-members for the headache community in general. Dr. Curtin, she's a professor of surgery, plastic surgery with a special expertise in headache surgery and nerve entrapment and nerve release procedures. She will be talking to us tonight about occipital nerve entrapment, which is very common in clinical practice and could be one of the major triggers for migraine headaches as well, and how to address them after failure of conservative treatments. I just want to give you a heads up to mark your calendar. The next webinar, it will be about headache management in the ER. This is a new topic in our series. We understand that appropriate management of headache is multimodal, and actually sometimes the first and only encounter between headache patient and any physician in general is the ER. So Dr. Piscatori will be addressing this important issue. If you don't know him, he's one of the most influential physicians on Twitter, and he holds lots of administrative positions in health, in public health in general, very well published, and you will enjoy the talk a lot. And then 2 weeks later, we'll have Dr. Yasmin Hoydonikics. She is from Toronto. She's a headache expert, pain physician by training. She will be talking about another very prevalent disorder that can be associated with the face and head pain, TMJ disorders, and diagnosis and management. Please share your questions and comments on the Q&A down, and we will be addressing them by the end of the webinar as always. If we don't have enough time, we post them on our website. You will have also free access to the recorded link by tomorrow. So I will switch now with Professor Dr. Curtin. Again, was very excited about this topic. Thank you very much for joining us. This will be highly educational for everyone who's practicing headache medicine, for those how to select those patients and appropriately refer them to experienced surgeons. Thank you very much for joining us.
Thanks so much for having me. I'm very excited to give this talk, maybe a little bit fearful, as this is sort of the surgeon's perspective, and historically there has been some suspicion about how surgery fits into this, but I hope to show you that maybe surgeons can be part of the team as well. So when you start surgical residency, one of the first sort of axioms you get is, well, you don't operate on pain. I mean, if you operate on pain, all you're going to do is you're going to get pain. And so surgeons also historically have shied away from the idea that you would do an operation to try and reduce pain. And, you know, you guys probably know this better than me, but surgeons also can cause a lot of pain. But I would say that not only are we pain generators, but we can also be a really important part of the pain treatment team. And especially if there's some nerve that is entrapped or a neuroma or something like that, we may be able to help make that nerve be in a happier state and help reduce the pain. So I've sort of changed my tune, and I try to teach my residents, and maybe you will also join me in thinking that sometimes in the right situation, in the right place, and the right patient, if you operate on pain, you can actually get happiness. So I think, though, to have this work, you really have to have a team. And I'm very blessed at Stanford and at our VA hospital to be part of a team where we have pain specialists, we have surgeons, we have a neurologist, we have radiologists, and we all work together to try and find the best path forward for each patient, the really challenging patients where we don't know what to do. And so having the surgeon be part of a nerve team, I think, is an important part to ensure that the correct patient selection is done. And so for me, I'm part of that nerve team. I'm a peripheral nerve surgeon, so I operate on nerves all over the body, and I treat painful nerves all over the body. We're just talking as we started here about the perineal nerve, which is another nerve I think is very interesting. And I'll tell you about some others as well. And I believe that nerve compression is a common pain generator. And if identified and treated, you actually can make great strides and help the patient feel better. And so this is nerve compression that's just beyond carpal tunnel. Everybody knows about carpal tunnel, but I think it's kind of crazy to think that only the median nerve at the wrist gets pinched. I think all nerves, as they transition, have the possibility of getting compressed. And transition points are when they change planes, when they go from deep to superficial, or when they cross a joint. These are areas that the nerve is sort of in possible jeopardy of getting swollen and compressed, which then can generate pain, sensory changes, and weakness. And so there are multiple nerves throughout the body, and one nerve can also be pinched in more than one spot. And we'll show you later the occipital nerve and how there's some thought there can be more than one compression. And so another nerve, if you're going to look at the ulnar nerve, it can be compressed at the elbow, but the person could also have some compression of the thoracic outlet. And so you need to be thinking sort of more globally. And as I said, there are a wide variety of nerves. And so in particular for head pain and headaches, there are some pain can be caused by entrapped nerves. And the occipital nerve would be the one that we're going to talk about today. And that decompression of an entrapped nerve can provide that patient some durable relief. So what I'm going to go over today is I'm going to review how the diagnosis is made. I'm going to review some of the evidence that is out there, an overview of sort of what the surgeon is doing and thinking, and some representative cases. So first, how do you find who this patient is that might have an occipital nerve decompression or occipital nerve neuralgia? So the pain distribution is very helpful. These patients complain of pain in the back of their neck. They'll often have it be more unilateral than bilateral. It can extend from the back over the top of the head and into the eyes. It tends not to be postural. So when I have a patient who tells me that it's much better when they're laying flat, they have a lot of other sort of postural symptoms, I'm thinking of, is there some other cause of this head pain? Could this be a CSF leak or something like that? Because in general, patients with occipital neuralgia are not saying, oh, it's so much better when I'm laying flat. And really, they have pain. They can point to and say, oh, it hurts right here onto the back of their head, and they'll be pointing right over where the greater occipital nerve is entrapped. And I'll talk about this landmark for surgery a couple times, but if you take 3 centimeters down the midline caudal to the occipital protuberance, and then just 1.5 centimeters off midline, that's normally the area of entrapment. And it's just amazing how many patients will say, well, it hurts right here. And that's actually the spot of entrapment of the greater occipital nerve. So when I'm looking at these patients, I look for that tenderness. And so as the greater occipital nerve is piercing from deep to superficial, like I said, when nerves transition, that's when they can be at risk. Also, I'll press on that area and they'll say, oh yeah, that's the spot. That's where it really hurts. So that I'll look for the lesser occipital nerve. And I think that failure happens when you don't really appreciate all that's going on. And so I'll press on each greater occipital nerve, and then I'll press on the lesser, which, let's see if I can get my marker here, which is just behind the sternocleidomastoid. So I just press behind the SCM. I have them sort of fire their SCM and I press, and they'll say, oh, it's sore there as well. I'll also sometimes press along the anterior scalene. Some of these patients have had some whiplash or neck trauma in the past, and they can have some anterior scalene pain sort of pushing on to like C5, C6. And it's just a good thing to note before you're going ahead with surgery. And then I'll press over their medial scapula for the dorsal scapular, where the dorsal scapular nerve runs. And I think this is a really important nerve. I'll talk a little bit more about it because what I've noticed is that this seems to really be a common sort of co-diagnosis with people with greater occipital neuralgia. I was just telling Samir and the other crew that as I was preparing for this talk, I went back and looked through all my patients, and I was just struck by how many of them, after their head pain was improved, really were complaining about shoulder pain and dorsal scapular pain, and that we had done some injections and things focused on that and helped them. So this is something when you're looking at greater occipital nerve to start looking for as well. So the dorsal scapular nerve, it comes from anterior off the plexus and goes straight back and pierces the trapezius. It's then running down just on the medial scapula, sort of where this cartoon is sort of pressing. This is where it hurts. And I think that the entrapment is often as it goes underneath the superior edge of the rhomboid. So if you think about dorsal scapular nerve, a lot of people think it's the trapezius, and I think that could be a compression, but in my experience, it seems to be it's more at the level of the superior edge of the rhomboid. And so that's where we actually give a lot of our diagnostic blocks to try and figure out some dorsal scapular nerve entrapment. So then you would do a sensory exam on your patient. Now, so you've sort of pressed on everything and you've seen where it's sore, tender to palpation. Some patients will have some allodynia in the posterior head and the greater occipital nerve distribution. You'll hear people say, well, it really hurts when I brush my hair, or it feels weird, or it's numb in that distribution. But I would say that these are not typical, that this is more the exception than the rule, and that typically sensation is more normal in the distribution, but that you should check it. So for me, part of the diagnosis, really the critical component, is a very good block of the greater occipital nerve with substantial pain relief. Those patients who have greater than 70% relief with a focal block just of the greater occipital nerve or nerves and have tenderness in the correct distribution, I think are likely good candidates for some intervention. For me, I'm very blessed to be part of the nerve team. Our pain team. Our pain team performs these blocks under ultrasound, and they also can give me some qualitative sense sometimes of what the nerve looks like under ultrasound. There have definitely been patients who they say, you know, really does look swollen. I think this person would be an excellent surgical candidate. So I'm a surgeon, so I'm going to talk about surgery, but as I said, I'm also part of this team. And so most of my patients have tried more conservative treatments. Many almost all have tried Botox and have found relief from this, but it's not durable enough, or they start getting frustrated having to come back. So that's an excellent patient to have consider for surgical intervention. They've already shown you that they can get improvement with the Botox. It just may not be in durable enough relief. Some of my patients have already had our ablations of their greater occipital nerves, again, with good relief, but not durable. A common story would be they had an ablation, it worked. They got a second one, it didn't work as well. And so then they're going to come to me for relief. And then also many of them had medication trials, and they're frustrated with that and looking for surgical intervention. So the evidence, of course, we can use more. A large amount of the evidence comes out of the Cleveland group. I think the sort of most amazing study is that they actually did a randomized controlled trial with sham surgery. So they made the incisions, and this was for all different trigger points. Occipital is part of it, and I'll show you some of their results, but they made sham incisions. And then on some patients who got the intervention, they did the decompression component. And for those who didn't, they just closed. And what they found was that for the group that had the decompression component, for all the nerves, they had 57% of patients had elimination of their migraines versus 4% with the sham surgery. And you can see the improvement. There was also a systematic review done fairly recently that greater than 50% reduction in occipital migraine headaches range from 80 to 94% in the literature of case series and things based on a surgery for the occipital nerve. So this is a busy slide, but this is from that study of the randomized trial with the sham surgery. And you can see they have the occipitals sort of here, as well as some of the other sites. And what they have is, what percentage of patients had elimination versus the ones that had sham surgery. And so there were they did many different measures of success, and found that this decompression was better than the sham surgery. They then followed up these patients, it's about 80 patients, and they looked at long-term results, and that they did find that those who had, that the results were fairly durable, that you didn't have this maybe lasting a year and coming back, that it seemed that it was a long-lasting relief. And so, well, what are the risks of this surgery? And looking through the literature, itching seems to be not uncommon, but this seems to be more for when they do stuff in the front of the eyes. Numbness, and so I have definitely seen that where people will say it's numb on the nerve distribution of the greater occipital nerve, but that tends to improve over time. There were some neck stiffness and weakness in the literature. I haven't seen that in my own patients. What I have seen is that other trigger points emerging is actually fairly common, where patients will say, well, like this does seem better. I think we've made some progress on the posterior head pain, but this shoulder is really, really hurting me. And I'll keep kind of harping on that because that seems to be an important thing that maybe we can improve upon going forward. So just kind of the schematic of the posterior head and the nerves that we're going to be thinking about when we are doing surgical decompressions. So we're mostly focusing on the greater occipital nerve, and I'll show you a nice picture of the different compressions sites. And then patients do have also entrapment of the lesser occipital nerve, as it's just posterior to the sternocleidomastoid, I think less commonly. The third, which is just in the center, is really tiny. And there have been some studies where people cut this during surgery or don't, and it doesn't seem to be something that makes a difference in the outcomes, the third. So this article is the one that is sort of the guide for most surgeons as far as how to think about the possible entrapments of the greater occipital nerve. So when we're kind of going after it, this is what we're thinking. And really, this is the spot that is the primary compression. And this is that spot that's going to be 3 centimeters down and about 1.5 centimeters out off midline. And patients inevitably point like, this is where it hurts. And so when you are doing the decompression, you find the nerve in this area. And then there's a little tight like ring of fascia. You just open this up. You're not cutting the whole muscle. You're just making a little window in here. And then you follow the nerve out distally, or not distally, I guess cephalad. There are sometimes a little blood vessel that crosses, and you can ligate that. And then I think the other second most common entrapment site is this trapezius tunnel that they talk about right here, as the nerve again is transitioning from deep to superficial through the trapezius at the sort of nuchal line. And so I think the thing I was sort of most struck by was that how big this nerve is. I mean, it's way bigger than a digital nerve in a finger, and which is supplying sensation to your hands. And yet, this is just a sensory nerve to the back of the head, but it's quite a sizable nerve. So when I am doing the surgery, the technique, it's a general anesthetic, and the patient is laid prone. I think some people may be able to do this under sedation. I don't know how. I do it as a general. I make a longitudinal incision that's about 4 centimeters long, and then I lift up the skin flaps in both directions. I don't necessarily release both greater occipital nerves. If only one is hurting them, then I just release the side that is sore. You lift up the skin flaps, you go underneath the trapezius, and then you go laterally and you find the greater occipital nerve, and then you basically just go up and down over about 7 centimeters, making sure there's no fascial bands, little blood vessels, or things that could be pinching it. And then you close. If the lesser occipital nerve is tender, then I will release that as well. Same procedure, and I just make a little incision at the point of maximal tenderness. I have the patient pointed at it, and then it's just normally behind the sternocleidomastoid. I put some dissolving sutures in and Dermabond to seal the skin, because it's hard to put a bandage over on the hair. They can shower in 24 hours, and then no heavy lifting or straining for 3 weeks afterwards. Typically, it's not a particularly painful, I mean, it's sore, but of the operations that I do, this is not one of the more painful ones. There's no bony work and not a lot of muscle distraction. We're between muscle planes. So I have been doing greater occipital nerves for a while now, since about 2015. And I think it's technically a medium difficulty. It's not an easy operation. So when you're thinking about partnering with someone, it's not something that is easy as a carpal tunnel, let me say, as a comparison. The nerve is quite deep. And finding those planes below trapezius and finding the nerve, it actually is a little bit challenging. And also there's a surprising amount of anatomic variation. The nerve can start branching even below and from deep, and then pierce, and you can have branches sort of going right, left, and cephalad. And so when I find that, I'll find one little branch and I'll follow it down to the main root of it. So there is really quite a bit of variation. In general, it's a soft tissue operation. We're not asking a bone to heal or anything like that. And so really complications have been very minimal. Sometimes patients will have some sensitivity afterwards in the like in the surgical site, or some allodynia over the area. For those patients, and if I can, I like people to actually see hand therapy. This is a little bit of a crazy choice. I'm also a hand surgeon, so I know the hand therapists. Hand therapists are very trained in desensitization measures and gentle scar management. I sometimes feel that physical therapists push patients a little bit too much to do range of motion and strengthening, when I really want an early nerve case just to be desensitization, gentle scar management, gentle nerve glide. So I send my patients who are having tenderness and afterwards to have some hand therapy on their scar. I say it's scar management, and that's how they can put it into their scope of practice. And for the right patient, this is really a really great solution. So I was going to give you sort of a representative case from my patients. So this was a 28-year-old girl. She has had posterior head pain for years after a fall from a horse. She had responded well with Botox, but she was frustrated having to keep coming back, and she was hoping for something that would be more durable. So she had a ultrasound guided block of both of her greater occipital nerves, and had elimination of her pain for an entire day. And so this is sort of a picture intraoperatively. I don't really shave all the way up here, but so this is the occipital protuberance. And so it's going to be about at the edge of this 3 centimeters down and 1.5 centimeters off midline will be where we should find the greater occipital nerves piercing. And so we sort of center our incision over that area. And so here's kind of a bird's eye view after we have decompressed the nerves. Maybe they look small to you, I'm not sure, but they look enormous to me as far as these huge nerves. And right here where the vessel loop is where that muscle fascial band would be. And so we make just a little bit of a V in the muscle, releasing that tight fascial band. And so here's just another view. As you can see how that nerve is like making a real tight turn. It's coming sort of straight out, and then it makes almost a 90-degree curve to go cephalad, and it's going through from deep to superficial. And then this is her at her 2-week post-op with the sort of dermabond sliding away and loosening up there. So she had immediate relief of her pain after the decompression, and that is not that uncommon of a story for the right patient. Interestingly, what she hadn't mentioned to me was that she had nausea every morning when she woke up, and that resolved after her surgery. She felt this was very not painful, and she was actually back to work in 3 days. As far as postoperative pain for these patients, there are people like this where it's just, wow, this is amazing. I feel so much better. More typically, people say, it's sore. Like they feel the surgical soreness, but they feel that there's a change in the character of their pain, and that's a good sign that we're, probably on the right track. These are not patients who are calling me for a lot of opioids. This tends not to be a particularly painful operation. So when I was thinking about preparing for this talk, I decided I would just sort of go back and look through and make sure that I was telling you the truth about my outcomes. And something that really jumped out at with me was how common this sort of concomitant sort of shoulder or dorsal scapular pain was. I think it was in almost 20% of the patients that we did this release on for their occipital nerves were like, yeah, the head pain is better, but my shoulders are really hurting me. And so thinking forward, I need to do something about that, perhaps maybe do a steroid injection at the time of surgery. I'm not sure I actually would be really open to ideas on that, but that seems to be a common co-condition. And so what I tell my patients is that and then looking back at my results, this is probably pretty accurate, is that about 25% of my patients, they have terrific, great results, pain elimination. These patients, they are so excited. They, want to, get Christmas presents and birthday presents, and it's awesome. But that's not everybody. That's just 25%. Most of the rest of the people, they find that the surgery helps them. It makes them better, but not perfect. We know that placebo is a large part of any pain intervention, but I think that in general, it's quoted at about 30%. And so most people get more than 30%, somewhere in the 50%, 40% range. Better, but like it's still not perfect. Maybe the head pain is better, but the shoulders are hurting, or maybe one side is really great and the other side is not as great. And I said 10%, maybe it's slightly more, but like they get nothing. They say, I've done this whole surgery and it didn't help me. I still have the pain that I started with. But looking back at all of those patients, I don't think that anyone was worse for the procedure. We didn't have any major complications to speak of. So some other thoughts, just sort of as I was preparing for this talk. The question of sort of, well, should you just cut the nerve or should you do a neurolysis and just decompress it? There isn't a study that compares the two, but I just don't understand why you would ever cut a nerve and then cause a neuroma if decompression might be able to solve the problem and you keep the nerve in continuity. There are other nerves that can cause head pain that have been discussed and can be decompressed as well. I'm not going to be talking about that, but certainly people do talk about supraorbital, supratrochlear being compressed as they come out, again, transitioning outside, intracranial outside. I think that addressing all the symptomatic trigger points is something that I have learned. I started being quite conservative and it's just here, and maybe they were a little sore on the other side, just doing the one side, with the thought that, well, if they get their painful nerve decompressed, they're probably all their shoulder and neck mechanics might improve as they're not having so much pain, and these other things that are hurting them might also then subsequently improve. I really haven't seen that. And if anything, it seems like once the one is feeling better, they can feel the other sites a little bit more clearly. And so I think I have a lower threshold if I'm doing surgery and one side is really sore and one's only a little sore, I'll just release both the greater occipital nerves. If one and look to those lesser occipital nerves. And like I said, the dorsal scapular is an unsolved question for me. Peripheral nerve stimulation is also really promising. There's a lot of good evidence showing its benefit in this realm as well. Okay, I'm a surgeon, so I'm just going to say it. I mean, if you have a decompressed nerve, like why wouldn't you decompress it first? Make it happy, make it healthy. And then if that didn't work, we certainly use neuromodulation for the patients, those ones who it wasn't good, it didn't work at all, or it wasn't good enough. That's sort of a next thing in our treatment category. But sort of my bias is if we can make the nerves as happy as they can be, then potentially have durable relief of pain. So thank you. It looks like we have a bunch of questions, and I clearly talked really fast since I'm done a little bit early, but maybe that'll give us more time for discussion.
Thank you very much, Dr. Curtin. This was really very informative and exciting. It's an unvisited area, and we really need to keep educating ourselves and know when to refer those patients. So we have a few questions. I will start with, where's the first one? How to differentiate clinically between occipital neuralgia and upper cervical facet pain? Thank you.
Yeah, and I think that the tender to palpation is actually very helpful. If you know that it's 3 centimeters down and it's 1.5, and you press there, I mean, the patient will say it's right here and it's not very deep, and you press right there and they're like, oh, that's the spot. I think that is very helpful. Number one. Number two is I think the ultrasound guided block can be very helpful. It can show you that the diameter of the nerve, does it look swollen? And also just putting the local right there instead of getting deeper can help you sort of differentiate, is it a more proximal problem versus a more distal problem?
Yeah, thank you. And actually, I think this is our role as a pain physicians or neurologists to make the appropriate diagnosis before sending the patient to a surgeon for such a procedure. So I would say this question is important. And occipital neuralgia is a nerve pain, neuropathic pain. Facet pain is a mechanical pain. So it's usually present differently. Occipital neuralgia, as Dr. Curtin said, you cannot miss it. It has this like almost Tinel sign. You tap on it, it will trigger those electric lancinating pain, sharp pain. Facet is rotating the head, cause mechanical pain more. I have a question for you since we are talking about this. So you need a good response to the nerve block. And what do you mean by good response? Is 50% enough for you to consider this 100% relief? What's your threshold to see if this is true or not? Or since you work with, I know your team, they are very good in ultrasound, because I will say this is a good opportunity for ultrasound to use it as a diagnostic tool. You can measure the diameter of the nerve before, I mean, distal or proximal to the semispinalis capitis muscle. So what's your threshold to accept this patient as a good prognostic block for a surgery?
Yeah, I like the sort of 70% range. That makes me feel pretty confident that we're in a good place. I really like it when the patient said, oh my gosh, that was amazing. Can we do it tomorrow? Like, that was amazing. And you know, when you've blocked someone and you've gotten it just right, that's what they say. It's that they're so excited.
So second question, I think it was related to one of the studies that you mentioned from Cleveland Plastic Surgeon Group. How did they get consent for the surgery? I don't know if you know.
Yeah, I mean, so, you know, there is, I don't know, but I mean, there is a history of sham surgery. You know, there was a big study within the VA some years ago on knee arthroscopy for arthritis, and they did where they just stuck the scope in and pulled it out, and the other one they did the surgery, and they found that they were exactly the same. So you know, there clearly is a path that is legal for this type of thing to do sham surgery, but yeah, I don't know how you do it.
Next question is, what percentage of occipital neuralgia patient usually will need such surgical decompression? I mean, in your experience.
Yeah, I don't know. And like I said, I'm very blessed because I'm part of a really great team. And so my patients are often beautifully worked up. They've trialed things, and then, you know, this worked, but it wasn't durable, or, you know, we think this person, and they come to me. So almost every patient who comes to me is already, you know, tied with a bow. And so I have to say, I'm not sure when you're out in a group and you're seeing all comers, what percentage of patients are not those.
Yeah. I agree. Yeah. I want to emphasize what you mentioned, and I think I posted this on Twitter. It's a team approach. It's a team approach. The first encounter, usually it's even primary care doctor refer to a neurology headache specialist, refer to interventional headaches. If the diagnostic block was really a wow, I will say definitely either consider neuromodulation or nerve release if you have the expertise available. Because honestly, I can think only of three surgeons that they do this kind of procedure. So, do you get referrals from out of state for specifically for this procedure?
Some. I think that what people that this is a growing practice. I will say, in our plastic surgery residency, all the residents want to learn how to do this. So I think there's a recognition that this is something that is beneficial. It's not, so challenging. You don't have to have an inpatient stay for seven days or something like that. The residents are very interested. People are touring the world. I've had people come visit me from other countries. So I think that you will find that there will be more and more surgeons who have this capacity, and not just for occipital neuralgia, but just the idea of peripheral nerve and treating peripheral nerve as part of the pain options is growing.
And the same with this, I think what you need more is people are experiencing it in sonoanatomy, how to visualize the nerve by sonography. And a few years ago, Dr. Sousa and I, we actually published that. It was very nice, eye-opening at that time. This was maybe 10 years ago. We measured the caliber, the diameter of the nerve between the inferior oblique muscle and the semispinalis capitis muscle, and then after it leaves, because some of the old anatomy texts saying that the nerve does not pierce or go through the semispinalis capitis, which in real life, actually, most of the time it does.
Yeah.
And as you said, I didn't know this paper that you referenced. It does. It goes through the semispinalis capitis muscle before the trapezius aponeurosis. And yeah, at that time, we injected botulinum toxin around the nerve and the muscle, and it was okay. Next question, I think you mentioned it, but I will read it. What is the place of occipital neuromodulation or stimulation for this patient? Pre-decompression or after?
Yeah, but like I said, that my bias. But my bias is if a nerve is compressed and you can decompress it, that's a good place to start. I think this is really low risk. And if it works, great. And then neuromodulation is then for those patients where it's not enough, they still are hurting, or it didn't work, but they still do well with a block. And so there are those patients.
And I just want to emphasize that this is nerve release or decompression. It's not section in the nerve like the old school. So you are not causing neuroma, as you mentioned, or deafferentation pain. So it's really a minimal invasive surgery, I would say. Next question, actually, it's a half a page. So I will try to summarize it. I know it from Dr. Ansari, and I would have expected this question from him. And we mentioned this prior to the talk. It's basically how you differentiate occipital neuralgia from occipital migraine or migraine headaches or cervicogenic migraine. And do you think that like some of your patients that you did this surgery were true migraine? And he mentioned specifically, you mentioned a case that nausea resolved after the surgery. So I think usually it's migraine. So maybe it's for migraine as well.
Yeah, and so I think that the language is often very challenging and overlapping. So many people will be just given the diagnosis of migraines without maybe sort of a really rigorous accounting. And then also, perhaps there are also people with occipital neuralgia who have migraines as well. I mean, all your posture changes when you have this problem. I mean, the patients come into me and they're like this. And so how that doesn't change everything and all of the head, it does. I mean, it must change things. They can't move their head. They're like this because it hurts so much. And so I think that the language, it gets confusing and blurred, and there's probably some overlap that happens.
Next question, how long does the satisfactory pain relief last after surgery? And do you repeat for recurrent cases?
Yeah, so I think that there are some people where it's very durable. I've definitely had patients from 2015 who still have pain relief, and I know this because they came back for their carpal tunnel or their perineal nerve. So I've done other surgeries on them. They're like, oh yeah, that's great. So I think it can be very durable. I have had one lady that I did do a re-release, but she never really got better. And I think that that was a technical error on my part where I must have not fully released it. So she had, we did both sides. One side was great, one side was hurting, and even and it was more sore. Our team did an ultrasound. They're like, it's really swollen and entrapped. You missed it. And so we took her back and we re-released it, and that did fix that one. I have not had someone who's had a recurrence in the true sense of like a carpal tunnel. We know 10% of carpal tunnels have recurrence. They had symptoms, it got better. Say 10 years later, it comes back again. I haven't had that, but you know, it's only been 6 years that I've been doing it, so that may still be possible.
Next question, nice talk. Interesting that the nausea decreased with this young female post-op.
Yeah, I know.
So I think this was addressed. It was an overlap diagnosis between migraine and occipital neuralgia. And actually, honestly, with any patient with severe pain, if you have severe pain, you might have nausea with severe pain. But this tells you that, and actually, it's not uncommon that headache patient, they carry more than one diagnosis. So they can have dual diagnosis of occipital nerve entrapment as well as overlapping migraine. Next question, which it's very important question. I like, is it possible to decompress the posterior auricular nerve?
Posterior auricular nerve. So not the greater auricular nerve.
I think she meant the greater, the whoever asked the
Okay.
question meant the
Okay,
greater.
I was just making sure I was. I have to say I learn about new nerves like every day. Like posterior femoral cutaneous. Who knew? Now I know. It can be entrapped. So posterior, the greater auricular. I think it would be possible. I mean, again, you're thinking of a transition as it goes from deep to superficial as it wraps around the sternocleidomastoid. I think ultrasound again would be really, if you could do a lovely a dynamic test where you're watching it and you could see that there's a change in caliber and that it was really sore while you have the probe over that, that would be probably fairly interesting. It would be pretty low risk to just make a small incision and then just look up and down, because once it goes on the SCN, I don't think it would be entrapped because it's pretty superficial. I think it would be that transition point.
Actually, I remember a few years ago, I don't see this recently, so maybe the technique changed, actually with facelift surgery and in the scar behind the ear and with typical nerve pain. It's not just nerve pain along the scar, it's a nerve, it's a branch of this greater auricular nerve. And we tried everything. I think we ended by putting a wire, an implant. But I don't see them often now. Do you think that, I mean, plastic surgeons are aware of the
Yeah,
small,
they
minute
should be.
branches?
Yeah,
Yeah.
and so that's like a great, like, when do I think neuromodulation first? So when you have a scar and you have a nerve that's injured, then I think neuromodulation before any like neuroma surgery. There are neuroma surgeries, they're not awesome. The nerve is already damaged from the surgery. So for those patients, steer them to neuromodulation first. And if that doesn't work, then we can explore the neuroma.
100% agree. Next question, same. When do you recommend surgical decompression? After failed radiofrequency ablation or after neuromodulation? I think.
Yeah, I mean, I like the patient who had a radio frequency ablation. It worked. It was great. Maybe I got 6 months, but then it came back and I don't want to keep coming back. Like, that's a perfect surgical patient because you're on the right track. They did great. It just wasn't durable.
Very important question about, again, neurosonography, or actually this is MRI neurography. Did you use high-tech MRI imaging to document physiologic compression like in carpal tunnel?
No, we do a lot of MRI. We have a wonderful radiology team. The the greater occipital nerve, I think, is a little bit small for them to be able to really see increased signal. The nerves that we've been really pretty effective for are sort of like thoracic outlet, C8T1. You can see things. But once you start getting to a smaller caliber, it's very hard for them to be able to tell if there's increased signal and where. It just hasn't been effective.
Actually, very nice question coming. Any rule for neuropsychiatric clearance? I mean, I would say evaluation prior to compression as we do in neuromodulation.
Yeah, I think again, possibly, but I'm lucky and blessed, and my life is, I can be a little bit free because these patients have already been through the pain system. They've already been, referred from my pain physicians to me. They've already done a bunch of interventions, the Botox things, and the patients have done well. They don't send me patients that they think are not going to be able to do surgery. So I like I said, I'm pretty blessed.
Yes. And I will say, if you think that the patient will need a psychological evaluation or clearance, I will say consider other options first. So a good, and actually, we learn a lot from the questions, so please keep them coming, and we post them on our website if we cannot finish them. How much anatomical variation did you see with the occipital neuralgia surgeries?
A lot. Like I was saying, the thing that I thought was most striking was that it can start branching quite deep. And so when you get under the trapezius and you're looking at it, sometimes all you're finding are small branches, and then you have to follow them down as they come down into the root. So, yeah.
Do you ever advise Botox injections in the inferior obliquus muscle? How many units?
Oh, that's yeah, no, so I don't advise that or the units. Like I said, that's my partners. And then if I have someone who I very rarely is it someone who hasn't already gone through that's seen me. So I don't get the first diagnosis of pain. They're normally already worked up.
Yeah, I would say that it's rarely that the occipital nerve goes through the inferior oblique muscle. Usually it wraps below the inferior edge and then runs between it and the semispinalis capitis and then pierce the semispinalis capitis. So if I would inject botulinum toxin, I would inject it in the semispinalis capitis. Usually 20 unit total, 10 and medial and lateral to the nerve. How is the exact site of compression diagnosed? Is it by ultrasound or MRI? Same question about sonography or neurography.
So the exact site is basically based on the experience of doing lots of these, right? It's same with carpal tunnel, that we know it's at the median nerve. We know that that nice diagram I showed you where it's piercing seems to be the most common place. The other thing is that patients will often point to where the compression is. They're like, it hurts right here, and so that's actually also pretty helpful. Ultrasonography is, I think, beneficial. They're going to get a block either way, and that's also a really nice time to see if you can see some changes in the caliber of the nerve or if it looks swollen on ultrasound.
Is there a rule for C2 ganglionectomy?
Not in my practice. So that's not where I would go. So I'm not sure.
Yeah, I'm not aware either that anyone is doing this recently. I saw it only when reviewing the literature. It was done years ago as a part of cervicogenic headaches. I think now with the C2 DRG block and RFA, I didn't read about any reports about this recently. What are your thoughts on non-surgical decompression with EpiMed, needle, or neurohydrodissection with ultrasound?
Yeah, I think this is something that's really emerging. Hydrodissection is something that I know people are doing a lot more. I don't know. I mean, because it doesn't quite make sense to me. If you think that it's scarring, but why would there be scarring, right? So you do the hydrodissection to have the break up some adhesions. So if you think there's adhesions, so it would make sense to me if you say, well, this person, maybe they fell off the horse, they banged their head, maybe there was some bleeding, and you think there's some adhesion. So when they go like this, it sort of tethers it. That might make sense. But if you think it's just compression, I don't understand why that would work, because then it would be more the sort of anatomy of the nerve and the fascia. So there are also some of these like needling, things like that. That could potentially do something if you could sort of needle and sort of loosen up the fascia under ultrasound. That might be something that actually would change the anatomy. I don't know if anybody's done that. I know there's a lot of people doing some of these things for carpal tunnel. So it might be that you learn things from carpal tunnel and then you apply them to other nerves around the body.
All right, I think this will conclude the questions. We answered 19 questions. If you have any more questions, email it to the office and we will try to address them. So thank you again very much, Professor Dr. Curtin. This was really an eye-opener for most of us. And we would thank you for volunteering your time to educate us. Thank you all who joined us, and we'll see you in 2 weeks.
Thank you all.